Thank you, Shripriya. Thank you, everyone, for joining us again today evening. As Shripriya was mentioning, today we'll be talking about the management of emergencies in palliative care. So I think we've heard in between here and there in some sessions about the emergencies, and I think palliative care in emergency department is something which is really evolving these days. But today we'll be talking about the common emergencies that we see in a palliative care situation and the approach to palliative approach to such emergencies. So it might be slightly different from what you have been practicing or might be assuming, but yeah, the approach will be slightly different. The focus might be slightly different. So today we have as a faculty Dr. Vineetha. Dr. Vineetha has many years of experience in working in palliative care, mainly with corporate hospitals, I guess. So many of the feasibility of such emergency management can be discussed with her really today. And she has done her post-graduation in palliative medicine from Cardiff University. And currently she is doing her post-graduation in community medicine from Amrita Institute of Medical Sciences, Cochin. Welcome, Dr. Vineetha. Thank you so much for agreeing. Hope you're all well and safe in good health.
Hi, good evening, Sridevi, good evening, Sripriya, and everybody over here, all of you here. Today I have been assigned with the topic emergencies in palliative care. Let me first just try to share my slide. I think my slides are not, and there's always things being done in such a way, or sometimes a patient is taken to the ICU. So we have been unlearning in this process as you've been introduced to palliative care. And today, ironically, we are talking about emergencies in palliative care. So what do you think could be emergencies in palliative care? Yes, you can put it in the chat box. Can I have a few answers in the chat box? What do you think are possible emergencies in the palliative care? Yes, Dr. Ria says extensive pain. Dr. Nishan says acute conditions. Yes, could you be a bit more elaborate on that, Dr. Nishan? What kind of acute conditions are you having in mind? Dr. Arun says severe pain, severe bleeding, right? Dr. Abhishek says acute dyspnea. Again, Dr. Meena also agrees to that. Yes, Dr. Abhishek says hemorrhage. Dr. Ria again says severe headache. Wow, that's really nice. You've got a big long list over there, right? Dr. Banerjee also says bleeding from the wound. And Dr. Shiva Kumar says bowel obstruction. Yeah, you're going to have like separate classes on that. So Dr. Sanjan also agrees to that intestinal obstruction. So that's really nice. You have a big long list over there. So we're going to look into many of them today. But due to the time constraint, I would be kind of focusing on 3, but the rest of them we shall go through as case scenarios. All right, we will be discussing rather than me talking. All right. So in very simple terms, what is an emergency? An emergency is an acute injury or illness that poses an immediate risk to the person's life or long-term health. So that's what we were discussing. Can there be an emergency in palliative care? And I can see that all of you have readily agreed. You have a long list to tell me that yes, there is every need for an emergency in palliative care. Now, yes, Dr. Delners also adds here bleeding and severe nausea and dehydration. Yes, thank you. And before I get on to discussing further on emergencies in palliative care, I would like you to look into this graph that all of you are very familiar with. Yes, I know you have seen this before. And where does palliative care start over here? Yes, you can see the curative phase there, you can see the palliative care phase there, and then you can see the red bar over there, which is EOLC, end of life care, and then you have the green one, which is bereavement care for the family. So I would like you to just tell me, where does palliative care start for a patient? Right from diagnosis. Yes, Arpita, Alma, everybody says right from the diagnosis. Dr. Delnaz also says that's wonderful. And that's exactly the answer. It starts right from diagnosis. And do you see how that the blue triangle over there is just progressing? And that's exactly how it is. Right from diagnosis, when there's a lot of emphasis given for curative care, but as time progresses and as the disease is progressing, the role of curative care comes down if the disease is not controlled. Where if the disease is controlled, of course, it's, the curative care takes the entire course. But here again, there is palliative care right from the diagnosis. It's supporting the patient all through. And if the disease is progressing, palliative care takes over. And as you can see, it's only palliative care when it comes to end of life care. And then again, palliative care is also about bereavement support for the family, right? So why I wanted to talk to you about this graph over here, why I wanted to talk to you about this course over here is because emergencies are dealt separately, are dealt differently in this phase. That is, when you are dealing with a patient in the curative phase, you're more aggressive. You are trying to do things to save the patient. But as you move along, as the disease is progressing and as palliative care is taking more and more role over there you give more emphasis on symptom control rather than prolonging the life of the patient along with it. Okay? Yes. So moving on. This is what I would be dealing with in this 1 hour time. Spinal cord compressions, superior vein cable obstruction, and terminal hemorrhage. And I did ask for you a list of what are the possible emergencies. So when you have an emergency like that, the $1,000,000 question is, when do you treat it? Does this emergency have to be treated? Which phase are you in? How aggressive should you be? Now the question, I have here 1, 2, 3, 4, 5 questions, and these are 5 questions that has to go through your mind before you think about managing your patient. Ask yourself, is the problem reversible? The patient is having CA ovary and is having a severe a pleural effusion for which she is brought to you today with severe breathlessness. She's almost in her terminal stage. She's probably got a couple of weeks ahead. So are you actually going to think about putting a intercostal drainage tube and put the patient through the procedure of having an interventional procedure, having pain, of inflicting pain by putting in a tube such that she can't even move when she's lying down? Keep her fastened to that bed. Or are you actually going to bring down her symptoms by giving her the right medications? Will you be actually able to reverse the situation over here? Or is it going to actually improve the patient's quality of life? She came to you with severe breathlessness. So are you actually going to give her back a quality of life with decreased breathlessness at the cost of pain of that intercostal tube? Are you actually going to tie her down to the bed? Ask questions like these to the patient. Yes, so we go for symptomatic care and to provide quality of life is what Dr. Nishant tells. Right. So also look at what is the disease status of the patient. Is the disease status such that the patient has a good prognosis, or is the patient in the terminal phase where the prognosis is very, very poor? So what is the kind of chemotherapy that the patient is getting? Is the patient being given is the patient going through an induction phase? Is the patient going through a first line chemotherapy where the intent of the primary physician is to go all on and try cure the patient? So also you need to respect the wishes of the patient. What happens most often? The patient is suffering and the doctor goes out with the family and is discussing. So what do you think that we should do? A, B, and C is the option. What do you think we should do? And who is asking the patient? So do you think that the patient should be asked? Well, it is an emergency. And if the patient is conscious enough and has the capacity to take a decision, do you think we should ask the patient's wish? Yes, Dr. Arun says, if it gives relief to the suffering of the patient, emergency procedures need to be performed. Yes. And Dr. Nishant also says that, yes, we should ask. Yes, Dr. Meenu also agrees to that. We should ask the consent of the patient. So what if the patient is telling you, no, doctor, don't do that. I don't want this to be done. But you know it is going to help the patient. So then what do you do? Sit down, talk to the patient, tell about the pros and cons, the risks and benefits is explained to the patient. If the patient is in the capacity to take a decision, and also find out if the patient has been already discussed about these things prior, because what could be, yes, a lot of you have commented that counsel the patient. Dr. Arun and Dr. Delnaz also says counsel the patient. But I would like to add in a point over there that here is where the role of advanced care planning comes by. If you have a patient who is probably going to have a emergency in near future, you do suspect emergency coming sometime in near future, or if the patient is having a progressive phase and you know that things are downhill for the patient, it is always advisable to have a talk with the patient on what should be done in case of an emergency, because it gives time for the patient to think. Now, what is going to happen is that a single question to the patient might be influenced by the current mental status of the patient, the current psychological status of the patient. You do not know. He or she is probably very down because of the current progressive illness and how the treatment is not affecting her, or maybe because the family support is less, or she feels that she's burdening the family. So all this, the patient might just say, I don't want anything. I just don't want to live anymore. So this is where we give a lot of importance for advanced care planning. And then you take the wishes of the patient also into, you also give importance, right? And treatment outweighs the distress caused by the symptoms, like how I was saying, putting an intercostal tube and draining out the fluid, tying down the patient until fluid is drained out completely and reaches less than 100 ml, so that you can do a fluorodesis and then take the tube out. So all this, think about how much of distress you're going to be inflicting on the patient when the patient actually has only a couple of weeks or days left because he or she has a progressive disease, right? So these are I have just listed out a few emergency situations in palliative care, like very rightly said, very severe pain. So someone comes to you, a patient with prostate cancer comes to you with severe back pain. And you know that the patient recent scan showed multiple skeletal metastasis. So you know that you're looking at a bone pain here. So the patient comes in with severe pain. What are you going to do? You have learned in the previous classes about the ladder. And this patient has never taken morphine, absolutely morphine, opioid naive patient. So what do you advise a patient? You ask for a pain score, and the pain score is like 10 on 10, the patient tells you. What would you do? The patient is opioid naive. Where in the ladder will you start for the patient? Yes? Time for the chat box. Step 3. Dr. Abhishek says step 3. How many of you would agree to that? Yes, Dr. Arun also agrees to that. Step 3. Yeah, morphine. Okay. Haifa Salim also says step 3. Yes, Banerjee also says step 3, right? Yeah. Any more of you voting for step 3? Or probably you want to start with step 2, then move on to step 3? Right. So this is very severe pain. This is an emergency. So we are going to start on step 3 over here, right? And I'm sure you've had your classes on pain management. So you would have learned about that. And there is also this a technique of how you could start the patient on a morphine trial, where if your patient is opioid naive. So there's basically nothing. It is about making the patient lie down and take his vitals and take his pain score, and you give first an antiemetic, and then you give IV morphine like 1 ml, and you observe the patient for about 10 minutes, ask for a repeat pain score, and also check the vitals, check for any drowsiness, and then you repeat the dose if the patient doesn't have enough relief of pain. And after that, by the time the patient actually gets relief from pain, the pain score comes down, or the patient develops drowsiness, uh, or there is a severe change in the vitals, you stop the drug, and then you calculate how much morphine the patient actually requires, right? And then we have some other examples here, like spinal cord compression, superior vena cava obstruction, hypercalcemia, delirium, end of life symptoms. Yes, end of life symptoms are also an emergency. We always, in palliative care, we give a lot of importance for every patient, even if it is to live or even if it is to die. Live with dignity, die with dignity, right? And then again, other examples like hemorrhage, sepsis and neutropenia patients, seizures, and so on. So let's get on. We shall just go through a clinical scenario first. Raj is a 63-year-old gentleman who has been on androgen blockade for carcinoma of prostate. He comes to you today with complaints of severe back pain, and his pain score is 9 on 10. And he is also saying that he has some numbness over both the lower limbs. So what are we looking at here? Yes? Would you like to put your answer on the chat box? What do you think we are looking at? What is Raj suffering from? What is his condition? He's having carcinoma of prostate, now with severe back pain and numbness over the lower limbs. Yes. Here, Banerjee says it's spinal cord compression. Dr. Arun also says maybe spinal nets compressing the cords. Yes. Anybody else? Right. Hyper Salim also says spinal cord compression. Yes. That's what we are looking at. We are looking at a spinal cord compression. So what would be your action plan? Yes, Dr. Reshma also agrees to it. So what is going to be our plan here? How are we going to move forward with this patient? What would you like to administer? Step 3, strong opioids, corticosteroids. Okay, Dr. Abhishek says so. Then Banerjee also says dexamethasone. Dr. Arun also says steroid. Yep. Yes, Dr. L. Purnima also says steroids. Yes, Dr. Ajay says corticosteroids. Dr. Delna says morphine, steroids. Yes, Dr. Nishant also says pain management and Zoldria. Dr. Ambika says palliative RT. Yes, Hypersaline says IV morphine, steroid. Wow, that's absolutely wonderful. Yes. So all of you are right. And let's move on. So yes, we are looking at spinal cord compression. And this is just a diagrammatic representation showing the different levels of spinal cord injury and what your patient would probably be presenting with if they have an injury at any of these levels. So if it is something at the C1 to C6 level injury, your patient could have a quadriplegia where all the limbs are actually affected with a motor sensory deficit. Then if it is C6 to C8, complete paralysis of hand, trunks, legs, T1 to T2, arm, hand function and paraplegia. L1 to L5 injury, it's paraplegia, that is lower limbs. And S1 to S5, some of the patients can walk, but there could be many who end up with bowel bladder disturbances. Okay, right. Now, spinal cord compression is seen in about 5% of cancer patients. 10% of patients with vertebral metastasis develop spinal cord compression. And it is very subtle in the early stages. And by the time the classical signs appear, it could be too late. So many of the times, for patients who are coming to corporate hospitals, or they're coming to regional cancer centers and all that, and they are traveling for far off places to get specialized cancer care. And I know patients who travel hours together to reach. Sometimes there are patients traveling all the way from Kerala to go to Tamil Nadu. There are patients who travel from Tamil Nadu to come to Kerala. Just an example. So what happens is that patients sometimes attribute their back pain as a very casual process. They tell the physician or the nurse that, I'm having this back pain ever since last time I came here, because probably the journey is too much, not able to handle it. So generally what we do is that, we have a tendency to overlook this and we give a pain medication. Now, what happens here? If you do not think about this, if you do not foresee that probably you are looking at an evolving spinal cord compression, you might be just giving the patient an analgesic, and the pain might come down. The pain might come down for the patient, and the patient might actually get more involved with his routine activities, which is going to further aggravate the compression. So that is why it is very important for you to keep this in mind when you are looking at a patient with metastasis, especially when they tell you that they are having a back pain, or when they tell you that they are having a back pain, please examine the patient. Check the patient for sensory deficits, motor deficits. Most patients present with sensory deficits first before they can actually develop a motor deficit. So when your patient comes to you with back pain, you can always check for sensations, check for any deficit in sensations, and also check the power of the limbs. And this will help you to detect spinal cord compression early enough. And why is it important that we have to detect spinal cord compression early? Yes. What happens? Okay. So what happens if the patient comes a bit late and actually develops motor deficits and is telling you, yeah, actually now I'm having a weakness of my lower limbs. So what is the difference here? Does it make any difference to their treatment? Yes, Dr. Deepak says that it prevents irreversible injury. Yes, Dr. Ria says it can cause paralysis. I would like to highlight the fact that Dr. Deepak was talking about it causes irreversible injury. There are chances that your treatment could not actually reverse his or her weakness, right? So that is why you need to act really fast. Now, spinal cord compressions are common in multiple myeloma, cancers of breast, lung, prostate, bladder, kidney, and it is most commonly seen in the thoracic segment. Now, mechanisms basically is because the vertebral body, there is erosion of the vertebral body, and this is what is most commonly seen, and it invades into the epidural space. The vertebral collapse can be seen, or there is a spread that happens into the intervertebral foramen, or there could be an interruption of the vascular supply. And the patient presents to you with backache, which is increased on lying down, and root pains, which is increased by strain. They may very typically tell you, every time I sneeze, every time I cough, I get the severe catch in my back, and is this lightning kind of shooting pain that happens to my lower limbs, or to the front, to the abdomen. So sometimes they could tell you that they develop even stiffness or weakness. There's altered sensations in the feet, and usually it starts from below and ascends. And urinary symptoms and perianal numbness is also seen, but these are very bad signs. So before that sets in, you need to catch them early. Now, sometimes even by evaluating the patient, you can assess where the lesion is. That is the lesion above L1 or below L1? These are just some clinical findings that tell you where the lesion could be. So if there is a spastic paralysis, if there is increased reflexes, if there is upgoing plantars, and if there is a local and radicular back pain, it's more likely that it is above L1. And if it is below L1, mostly it is seen as a flaccid paralysis. There is absent reflexes, downgoing plantars, dermatomal sensory changes, and a distended bladder. Usually there is a very lax anal toe. This image is little moved to the center, but what I was trying to say is that do a clinical examination, localize where the lesion could be, and again, when it comes to investigation, what would you suggest? What investigation will you suggest to this patient to confirm that it is a spinal cord compression? Investigation of choice. Yes. Can you put down your suggestions in the chat box? What do you think is the best investigation for this patient? Yes, Dr. Nishant tells MRI. Dr. Paul, Dr. Arun, Dr. Reshma, Dr. Abhishek, Dr. Sanjana, Dr. Akoijam, and Dr. Nedelnas. Yeah, all of you. Dr. Ajinisha, Vignesh Sunil, Haifa Salim, all of you are definitely for MRI spine. And I agree with you totally. MRI spine is the investigation of choice. But what if you are at a setup where there is no facility for MRI? So at least go for an X-ray if you do not have the facility for an immediate MRI, and confirm your diagnosis. Okay. Yes, thank you for your responses. We shall move on. And like many of you suggested, what could be done for this patient in terms of management? Urgent intervention is something I would like to highlight, because we need to act really early. And again, we did get answers here in the chat box on starting the patient on corticosteroids, dexamethasone. Yes, here I have mentioned 16 milligram IV of dexamethasone, but there are situations like I myself have started patients on 40 milligram of dexamethasone, And ideally, dexamethasone is given for about 3 to 4 days. And how would you like to space your dexamethasone? Like, would you like to give it in divided doses, say 8th hourly or 12th hourly or once daily? Yes? How would you like to give dexamethasone? Your answers in the chat box, please. Yes, once daily. Dr. Paul says once daily. Yes. Yes, Dr. Deepak says bolus. Yeah. Yeah, if you are giving a bolus, how would you like to give it? Would you just like to push it? Or would you like to give it in 100 ml NS? Yes, Ajay says 8th hourly. Yes, we have different answers here. Yeah, before I get into the frequency, if you are giving dexamethasone, especially when you're giving a high dose, always remember that do not push high dose dexamethasone because it's quite uncomfortable for the patient. They tend to get this kind of crawling, numbness kind of sensations, especially very uncomfortable. Many of them do say that, they have this uncomfortable crawling kind of sensation in the anal area. So it is always advisable to go for infusion, short, small infusions of dexamethasone, probably in 100 ml NS, run it over about in 15 minutes. All right. Yes, infusion. Blood sugar will also be unpredictable after that, so slow infusion. All right. Yes. So coming back to the frequency from where we started. Yes. So some of you said once daily, some of you said 8th hourly. So the answer is we give it once daily because dexamethasone has a prolonged action. And if we are giving it once daily, preferably in the morning, if not in the afternoon, try not to give it at night because it might interrupt the patient's sleep pattern. Corticosteroids might cause some amount of excitement for the patient. So to avoid insomnia, it is always better to administer dexamethasone in the morning and or else in the afternoon. Okay, right. And then is radiotherapy. Yes, we did get this answer as well in the chat box. Definitely, there is an option of radiotherapy or surgery. But who would you suggest for radiotherapy? Who would you suggest for surgery? How do you make that decision? Yes, any ideas on that? Someone who's got a vertebral collapse in L1. Someone who's got a vertebral collapse in D10, L1, and L2. Who would you suggest what? Any answers? Chat box? I don't see any answers coming. Based on the patient's life expectancy, Dr. Akoijam Sunita says we take a decision based on the patient's life expectancy. Yes, any other suggestions here? First surgery and then second RT is what Dr. Meenu also says, right? Okay. Surgery and radiation both are correct answers for managing a spinal cord compression, but we do select a few patients for surgery, select a few patients for a radiotherapy. Yes, Dr. Shivakumar says vertebral collapse. Vertebral collapse. Okay, if there is a vertebral collapse, we go for surgery. An RT for less hopeful cases and surgery for imminent threat. Okay, and patient's performance status should be looked into is what Dr. Ambika was saying. Okay, so moving on. What I would like to highlight here is that indications for surgery. Say, suppose somebody just presents to you with severe backache and this patient has developed motor sensory deficits, and you're wondering, person in 40s has come to you presenting like this, you have no idea what it is. So you need to make a diagnosis here. You need a tissue diagnosis over here. There have been situations where there has been, spinal cord compression was like the first presentation. So if you do not have a tissue diagnosis, you don't know what you're looking at, surgery is a choice here. If the patient has already received radiotherapy, yes, surgery is a choice. If you're looking at a single lesion over there, surgery is the choice. If there is spinal instability and there is vertebral collapse, like you had mentioned in the chat box, yes, surgery is the choice here. If it is a cervical cord lesion, there surgery is the choice. Okay, so that is what I would like to say. If there are multiple levels of compression, in such situations, radiotherapy is the choice. And yes, there are situations where you might even think of giving a second round radiotherapy. Always have a multidisciplinary team to plan your management for such patients, because physiotherapy has a very, very huge role. Adjuvant CT may be, adjuvant chemotherapy may be helpful in certain situations like lymphomas, especially where, chemotherapy just melts the tumor. So you have a big lymphoma mass just invading into the spinal canal. Chemotherapies might be a good choice also over there, right? So always remember, you need an interdisciplinary approach here. You need the primary physician, you need the medical oncologist, you need the radiation oncologist, you need the physiotherapist, you need the psychologist, because that patient who has been running around, who's been the breadwinner of the family, is now tied down to the bed because he's become paraplegic. Complete loss of role. So definitely the person is going to be depressed. So that will amount to the patient's symptoms also, in terms of pain is going to be increased. So to manage all the different dimensions of the symptom, we know that a symptom is physical, psychological, social, functional, and spiritual. So in order to manage one symptom, we have to address all the dimensions. Right. So a spinal cord compression, remember, regaining ability to walk. 70% of those patients who came walking to your clinic are going to be able to walk back if given treatment at the right time. Those people who came with some weakness, only 30% of them will be able to go back walking. But those people who came with complete paraplegia, only 5% of them will be able to go back walking. So long-term management of these patients, mobility and protection of the spinal cord. And if this patient is going to be in bed for a long time, skin care, bowel care, very important. Coming to urinary system management, most of the times the patient is put on Follies. And sometimes we also teach patients who are who have been paraplegic for a very long time. We tell them also about self-intermittent catheterization. Then rehabilitation, psychosocial support. All these are very important. Okay. Now moving on to the next scenario. Tej is a 47-year-old gentleman, and he has completed his 6th cycle chemotherapy for carcinoma lung. And this was 2 months back. Now he comes to you saying, I must say I have been feeling as if my breath is stuck at my throat. Is it because that I have put on weight that I feel puffed up? So what are we looking at here? What condition are we looking at here? Yes? Yes, Dr. Nishant says SBCO. Yes. Dr. Arun also agrees. He says thoracic outlet obstruction. Dr. Purnima also says SVCO. Yes, lots of you all agreeing to the same. Dr. Sunita, Dr. Ambika, Dr. Reshma, all of you agree to that. That's lovely. So how are we going to manage this patient? we are looking at superior vena cava obstruction. This is the case of superior vena cava obstruction. So what are we going to do? How are we going to manage this patient? Is it by drugs? Is it by surgery? Is it by radiotherapy? Yes? What is your emergency management for this patient? There's a severe obstruction. He feels as if his breath is stuck in his throat. Well, Dr. Reshma says surgery. Yes. Then any more? Any more suggestions? I don't see much answers there. Okay. Dr. Meenu says steroids. Yes. Dr. Arun also says dexamethasone. Yes. Dr. Delna says medical management with steroids followed by surgery. Okay. Dr. Nishan says steroid, fluid restriction, some Lasix is probably going to make him comfortable. And Dr. Purnima says palliative RT. Yes, Dr. Ishwar says Lasix, IV cannula in the leg, radiation. Great. Then Dr. Sunita Devi says again steroids. Okay, lovely. Got so many answers here. And right ones too. Right. So, yes, Dr. Paul also says steroids and then surgery. Not sure about the surgery part, but most of the others are right. Right. So let's look on to superior vena cava obstruction. Caused by tumor in the mediastinum, preventing venous drainage from head, arms, and upper trunk. Commonly caused by carcinoma of lung. And then again, you also have other situations like lymphomas, cancers of the breast, esophagus, colon, testis, and also benign causes also. Okay. And mechanism of SVCO, it could be because there is an extrinsic pressure, that is the superior vena cava, you have an extrinsic pressure compressing it, or it could be the direct invasion of the tumor, or it is probably there is a central line sitting over there. Well, we know that for cancer patients, they need chemotherapies given very frequently. Maybe sometimes it is weekly basis, sometimes it is 2 weekly basis, sometimes it's 3 weekly basis. So it is very difficult to access veins for these patients, because every time a vein is accessed and a chemotherapy is given, you cannot reuse that vein for a very, very long time. So what is often done is that central lines, peripherally inserted central lines, are used for such patients. And what happens is that long-standing central lines can be a risk for intraluminal thrombosis, and this can present as superior vena cava obstruction. So usually occurs over weeks or months and sometimes what happens is that when this is very long standing, collaterals actually form around it. And sometimes the symptoms are not very prominent because of that, because the collaterals are keeping the circulation going. But when it actually appears acutely and the patient is in distress, it is an emergency. So yes, the patient can present to you like just how in this situation, our patient was presenting with dyspnea. Sometimes the patient can have a tracheal edema. The patient may be coming to you with stridor, or they may be, the patient might be also telling you, I have a severe headache, more on stooping forward. This is because of cerebral edema, also causing visual changes, or maybe the patient is having a bit of dizziness, syncope, swelling of the face, neck, arms. This is because of the outlet obstruction. And again, in terms of investigation, you will have to go for a chest X-ray, just like how we were saying that, yes, in the earlier situation, that is spinal cord compression, MRI was the investigation of choice. But what if you don't have an MRI facility nearby? You have to go for a chest X-ray. In the same way, here again, a chest X-ray can show you that mass over there, which is probably the one that is compressing the spine, the superior vena cava. Right? So likewise, an X-ray over here can be one of the important investigations which is going to lead to the diagnosis. Again, if the patient is in the curative phase of the treatment where you want to go full on, and venography can be done in the process of putting a stent to clear the obstruction. And management, yes, most of you have given different answers. So I'm just going to go straight into it. The patient definitely needs to be kept upright because the patient is breathless. And what happens when the patient is breathless? The patient is so anxious. So when anxiety increases, breathlessness increases. And when breathlessness increases, anxiety worsens. And this is a vicious cycle. And this is very often seen in all patients who present with breathlessness. So it is very important to cut the cycle. And that is why you have to make the patient calm. Sometimes we need to use medications to bring the patient to a calm level. And that is when most often we use short-acting benzodiazepines like lorazepam. So what I usually practice in my clinic is that I give my patient maybe a 1 mg or a 2 mg according to the breathlessness lorazepam tablet. I ask them to keep it under the tongue. Sublingual administration of lorazepam can be given, right? And dexamethasone, again, corticosteroids is going to be our best friend here again. I have written here 16 milligram IV, or it can be given subcutaneously. And here again, you need to know that it is given once daily, and it is preferably given in the morning or in the afternoon. It is again given for 4 days. Check for improvement in the symptoms. And further on, it is tapered and stopped once there is an improvement. Again, the 16 milligram is not the ceiling dose. I have sometimes given 24. Most of the times, actually, in practice, I do give 24 as well, 24 milligram. Then again, you can combine a diuretic along with it, like furosemide, 40 milligram IV or subcutaneously. And if the patient is dyspneic and the saturation levels of the patient is low, you can give an oxygen trial and treat the breathlessness. If the patient is severely breathless, you can even give opioids. Now here I would like to introduce two important things. One is oxygen trial and the other one is treating breathlessness with opioids. Now here, I don't know whether you have your class on respiratory symptoms. Have you had your class on respiratory symptoms? Have you been introduced on
Yes, yes.
Yeah,
Yes.
okay. Right. So you know that how opioids will help to manage breathlessness, right? So that can be used for patients if needed. An oxygen trial. So again, this also you might be familiar that we can give a bolus of oxygen and check for symptoms, whether there is a relief of symptoms, and if it is helpful for the patient, you can bring it down and taper it and stop. There is really need not actually give continuous supply of oxygen. Again, this is basically because we are trying to justify the use of such resources also. And it has not actually made a market change when it comes to patients with advanced diseases in palliative care, right? Now, emergency radiation therapy or chemotherapy, they all have important roles in shrinking the tumor mass and bringing down the pressure which is on the superior vena cava. Again, stents is also another option for management. Okay, right. So now moving on to hemorrhage. Hemorrhage is the next emergency that we'll be looking into. In the event of a severe hemorrhage or the risk of a bleed that is significant, you need to discuss with the patient or family what has to be done in case there is a severe hemorrhage. Okay. And now I am going to be focusing mostly in terms of hemorrhage that happens in end of life care for terminal patients. Okay. So in the event of severe hemorrhage or risk of bleed or a significant bleed, a discussion with the patient and the family may be needed to reach an informed decision about the possible treatment options. So if the patient is going to be at home, you need to be telling on what can be done if there is a severe massive bleed. And at this point, especially during end of life, if there is a torrential bleed, it is not appropriate to actually shift the patient at that point because it is not actually going to affect his survival. So what you need to do is actually control the symptoms, and you need to explain to the family what need to be done at that point of time. So how can you control hemorrhage? What do you think are the different ways with which you can control hemorrhage? There is a tumor mass over there and bleeding. So how do you think you can control it? Yes. Can I have a few answers in the chat box? Yeah. Yes. Dr. Purnima says pressure bandage, and then Dr. Deepak also agrees to the pressure that has to be applied, and also suggests tranexamic acid. Yes. Dr. Reshma also says pressure packing. Okay. Definitely, pressure bandage is important. Tranexamic and acid also helps a lot. You can give parenterally, you can give orally, you can give locally. You can break the ampule, dab your pressure bandage with it, and give a nice pressure. Yes, again, we have Dr. Ria and Dr. Delnas, all who agree to pressure packing and tranexamic acid. Okay. And yes, Dr. Arun also says surgery and cauterization in some cases. I totally agree with him as well. Right? Okay. So now again, as we are planning our emergency, we need to think of which phase of treatment the patient is in. Whether the patient is in the curative phase, whether the patient is in the terminal phase, and then we need to plan what kind of management we should do. Okay, so palliative RT is again another option that Dr. Nishant is saying. Right. So first, let us understand why has this hemorrhage happened. Run a checklist through your mind on what could be the possible causes of the bleeding. So is it actually the tumor that is causing the bleeding, or is it any drugs that is causing the bleeding? Is the patient on like steroids that is making the patient having a massive hematemesis? Or is the patient on like long-term NSAIDs that is causing a gastric ulcer and again causing the GI bleed? Or is the patient having some kind of clotting deficiency? The patient is having some thrombocytopenia or some hepatic impairment, or is the patient on some anticoagulants, which is actually leading on to the bleeding? So check for, is there any drugs that have to be stopped? Is there any condition which is reversible over here? So if the patient is terminal, if the patient is dying, yeah, actually these things don't actually matter much, because you are not able to actually correct it or reverse it. To reverse it is what I mean. So then it would be more of just support or to bring down the symptom. But else, if you are looking at a patient who is having a bleeding, you need to run this checklist in your mind. So you need to identify the patient at risk. Like we had already discussed, if the patient is already having a thrombocytopenia or this is a head and neck carcinoma, there is a potential for a torrential bleed. There is a probability for a torrential bleed. So you have to keep that in mind. Large centrally located lung cancers, that is also a high possibility. Now again, those patients who are having hematological malignancies, especially leukemic patients, where there can be derangement of the cell lineages, especially the platelets. These can also give rise to bleeding. Again, liver diseases also contribute. Now, if the patient is having a mass which is very close to the carotid, chances are when the ulcer is deepening and invading further, it can even rupture the carotid artery. Now, the risk factors for carotid artery rupture are again surgery, radiotherapy, or poor healing, or you can actually see a visible pulsation in the ulcer bed, or there is a fistula that you are seeing, or it's a very fungating tumor that you're seeing, or there are other factors like the patient is very diabetic. So you know that the healing process is going to be very less, right? And get involved a multidisciplinary team over here. You might need the primary physician, that is the oncologist. You might need the surgeon, and you might need a nursing staff. You might need a pharmacist if it is towards end of life. You might need a chaplain there. And also, advanced care planning is very important at this point. And you need to consider the patient's prognosis, the performance status, and also the patient's perceived quality of life and preferences. You need to respect the patient's wishes. And you have to discuss with the patient and the family. And this is where the advanced care planning comes. So here, the level of discussion may depend on how likely the NDP feels that the terminal hemorrhage may occur. Patients and families' knowledge and acceptance of the diagnosis and prognosis, and how much information the patient and the carer wants to receive. Patients and families' desired level of participation in discussions, and patients and families' coping strategies. All this are areas where which has to be addressed. Okay, and just to address a question in the chat box, Dr. Sanjana asked, yeah, how steroid causes hemorrhage. So that's basically when steroids are given for long term, and they could possibly sometimes lead to gastric ulcers, and which could mount to gastric bleeds. So that's where I put down corticosteroids, steroids basically, as one among them, okay, as a risk factor. Okay. In event of hemorrhage, use measures to a level appropriate to the individual patient. So I have given a list of the supportive measures. Yes, we did talk about what medications can be used. You can use ethamsilate, you can use tranexamic acid. Now you can use, it can be given parenterally, it can be given orally, it can be given locally. You can break the ampule, pour it in, and give a nice pressure. Or you can also use sucralfate tablets, which are powdered, and sprinkle it over the wound. All these help to control bleeding. Okay, and whenever there is a hemorrhage, you can call for assistance, and you might need someone to stay there with the patient. You do not know when it can become huge torrential bleed. Sometimes what happens in arterial ruptures is that it just flows out. It's sometimes very devastating for the patient and the family to see it happening. It's just like blood gushing out, especially when it happens from an artery. Now, also, it is very important to give psychological support to the patient and the family, because it's absolutely devastating, like I told you. And you can, the visual impact of blood, that is what is most devastating of all. So that is why we always recommend to have dark towels which are kept around the bleeding site to bring down the impact of blood. So this can be even prepared and kept pre-hand. We can tell the family, you can just keep some dark towels ready, so that in case there is a bleed, so that you can just keep it around, right? And here they say use of suction if possible. Of course, this is only possible if it is a hospital, and if it is in such a way that it doesn't cause distress to the patient. If it causes distress to the patient, even a lateral, if it is a hematemesis, or hemoptysis, maybe even a lateral positioning of the patient can cause a postural drainage. And okay, so again, if the bleed is very much, is causing a lot of distress to the patient, you can even think of sedating the patient at this point of time, right? Then, whereas in the little more curative side of the patient, if the patient is a little bit more on the curative side, you can think of even fluid replacement at this point of time. You can think of colloidal supports or blood products, or blood products to reverse the thrombocytopenia, to reverse the blood loss, right? Then, like one of you had earlier mentioned in the chat box, surgical ligation of artery, maybe for uterine bleeds, cancer of the cervix, or uterine cancers, when there is a torrential bleeding PV, you can even suggest the patient going in for ligation of the uterine artery. So these are all different procedures, but when it comes to patients at end of life, it is all about a conservative approach. So management, palliative radiotherapy, local pressure, ethamsalate, tranexamic acid, topical adrenaline, sucralfate, all these are different measures that you can use. Tranexamic acid, yes, 500 milligram, ethamsalate also 50 to 500 milligram can be used. Okay. So now when there is a acute bleeding, calm the atmosphere. Someone has to be with the patient. Airway management has to be done so that the airway is not clogged in case it is something like a hemoptysis or a hematemesis. Local control if possible. Sedate the patient if needed. Midazolam can be given. A short-acting benzodiazepine like midazolam can be given. Morphine can be given. And can be repeated if the patient is not sedated enough. And dark green colored clothes or towels can be used. And do not forget, do not just keep your focus on the patient. Always also remember there is a family standing behind you who is in a terrible state of affairs. So give enough support to the patient. To the family as well. Now, moving on, we have three clinical scenarios. I would just be quickly running through because I know that we have a case presentation. This, we can make it a very active discussion. Right. Margila is 46-year-old lady on oral capecitabine for locally advanced carcinoma breast with skeletal metastasis, was brought to you with confusion. She has been eating less and has severe nausea and vomiting. Yes, what are we looking at? What could this be? Brain metastasis with raised ICP. Okay. Yes. Dr. Nishan, Dr. Arun, Purnima, Dr. Purnima, all of you agreed to it could be brain metastasis. The patient has got an advanced disease, skeletal metastasis, and is now confused. Okay. And has been eating less and severe nausea and vomiting. Now, yes, Dr. Delna says electrolyte imbalance and brain metastasis. Dr. Meenu says delirium. Yes, Dr. Sajna thinks it could be hypercalcemia. Dr. Paul says brain metastasis. Here, I would like to just highlight the fact that she also has severe nausea. Now, a brain metastasis patient would be somebody who would be presenting more with a projectile vomiting, not much of nausea, isn't it? So we might also have to think about what are the different causes for confusion. So you put together all the different symptoms over here. We are looking here at hypercalcemia because there is a skeletal metastasis looking very evident over there, which could be one of the causes for hypercalcemia. So like you all have rightly said, we could be looking at a brain metastasis. You might have to do further investigations. But again, having a severe nausea might need you to think a little more. Also look for other symptoms which could be suggestive of hypercalcemia. I think we're having a case presentation on that. So we will be discussing more on that very soon. Moving on to the next case, Shanta, 47-year-old lady with carcinoma ovary recurrence on single agent topotecan, which is a chemotherapy drug. She had been visiting you with complaints of pain, and she has been started on step 3 analgesics. One day later, she is brought to you with irrelevant talk. Doctor, you prescribed my mother some heavy dose medication. Now she seems to have lost herself. What are we looking at? Yes, CA ovary, recurrence, pain. So we have started the patient on step 3 analgesics, and the very next day the daughter comes and tells that the patient is having irrelevant talk. What could it be? What could this be? What is Shanta suffering from? Opioid toxicity. Yes. Due to morphine high dose. Okay. What is this condition called as? I mean, what is this condition? What is this emergency we are looking at? Morphine overdose, delirium. Yes, I was just waiting for that term, delirium. Yes. So when you have a patient with delirium, you need to have the, again, you need to have a checklist of all the different causes of delirium. So can you name a few causes of delirium? Okay, here we have a person who's been just started on strong opioids and presented with delirium. What could be other causes of delirium? Yes? Any other cause for delirium?
Constipation.
Constipation, okay. Yeah, hyperammonemia, all that leading to delirium, okay. What else? Infections like UTI. Yes, Dr. Meenu says infections like UTI, hyponatremia. Dr. Nishant also agrees to electrolyte imbalance. Dr. Alma Rachel says severe pain. Yeah, sometimes what if the patient is not actually able to communicate, and the patient is like bedridden and stuporous, and the patient is actually in severe pain, and the patient is like acting all delirious. That could also be a reason. Yes. And anything else? So we've got the list of infections, the electrolyte imbalance. We've got constipation in the list. We've got severe pain, unaddressed pain. Yes, even the fecal impaction because of constipation could be causing the pain, and that could be a reason. Maybe there is a full bladder, the patient is not able to void, and that is causing pain. Could be anything. A urinary tract infection. Yes. Dr. Rashmi says urinary tract. Most often, sometimes in especially elderly patients, they might just present with severe delirium as a first presentation, right? So yes, thank you for all those answers. High fever and renal impairment is also a couple of the answers that I got here. So this is what it is, delirium. And yes, how will you manage it? Find out the cause, check if the cause, if it is something that you can reverse. If it is an electrolyte imbalance, you correct the electrolyte abnormality. If it's an infection, you treat the infection. If it is opioid-induced toxicity, you can administer some antipsychotics. Yet, you also can think of opioid rotation if it is very severe. Yes, renal impairment. Okay. So you have your whole list. Check for what is reversible here and then manage accordingly. Okay. And antipsychotics most often used is haloperidol. You can start from about 2 milligram, 2.5 milligram, or sometimes you need higher doses to control the delirium. It can be given 6 hourly. Or in severe delirium, sometimes in terminal delirium, we even give continuous subcutaneous infusions, right? So this is our last case scenario. Beena on chemotherapy for carcinoma breast post her first cycle On the 8th day of chemo comes with severe tiredness, fever, and rashes over the body. This is also an emergency. What emergency are we looking at? What emergency is this? Yes, what emergency is this? Sepsis due to neutropenia. Yes, neutropenia. Thank you so much for all those answers. So that is what it is. It is neutropenic sepsis. So if you have a patient taking chemotherapy, comes to you in less than a week's time, that's exactly when there is a severe fall in the blood counts. That's when neutropenia sets in. And at that point, if the patient develops an infection, the patient goes into sepsis. And if the patient comes to you with neutropenic sepsis, this is when you go for evaluation of take cultures, start the patient on IV fluids because the patient can go into shock. And before you get the report of the cultures, you start the patient on antibiotics, empirical antibiotics. Okay, and do your referral to the primary physician. All right. So with that, I did cross a bit of my time. We should go into the case presentation very soon, or else we will not get time for discussion. Yeah. Thank you so much. And we can go in for the case presentation. I shall stop my screen sharing.
Thank you. Thank you, Dr. Vineetha. I think, yeah, as you said, we'll start the presentation and then we'll take the questions. I think we had all the questions in between anyway.
Yeah, I think because anyway we were interacting through the process, so
yeah.
we've
So
been
after the
clearing it along.
presentation, we'll take up more discussion.
Yeah, sure.
Hello everyone, I am Dr. Atri and I am going to present this case of hypercalcemia, which is an palliative emergency. So this is a case of a female of 58 years old and she was diagnosed with breast cancer. Hospital negative, that is her ear, peer and her new status was negative. Now, when she was diagnosed with this, she presented to us recently with a complaint of loss of appetite, nausea and vomiting, muscle pain and body ache. She had intermittent constipation, generalized weakness, and she complained of always thirsty in spite of drinking adequate water. So I'd like to give a brief history about the course of the illness. She was initially diagnosed with the breast cancer in 2019, and then she received first-line chemotherapy with epirubicin and cyclophosphamide for 4 cycles, so 6 cycles, and then docetaxel for 4 cycles. This was completed in June 2019, which was followed by a toilet mastectomy in August, and her histopathology report for the surgical specimens showed that she had no nodal or nodes or metastasis present, but her tumor size was quite big. That was T4B. So she was started on second-line chemotherapy with oral capecitabine from September 2019. She was keeping quite well with this treatment until after 1 year, she started complaining of low back pain. When a PET scan was repeated, it showed a disease progression with multiple bone mets in clavicle, in D1 vertebra, left iliac bone, and pubic bone. A multidisciplinary tumor board decided for a third-line chemotherapy with vinerilibin and zoledronic acid for 6 cycles, and she completed this on December 2020. A repeated PET CT showed further progression of disease in bones and lymph nodes, and this time the MDT board decided for a fourth-line chemotherapy with eribulin 6 cycles along with zoledronic acid for bone metastasis, and it was completed in 2021. But this time, the chemotherapy regime was quite irregular because the patient defaulted it many times due to the COVID pandemic situation, and her husband being unwell due to cardiac problem. So when we examined this patient, her vitals were found to be normal, but her movements were sluggish and she looked dehydrated. So this treatment we did for and investigations we did for this patient was that we again repeated her PET CT scan and checked her for her calcium level, the PET CT scan showed that the disease has completely resolved in the lymph nodes, but it has a progression in the bones. Her calcium was found to be 14. Her parathyroid levels were normal, and her liver and renal function assessment was normal. So the psychological aspect to this patient was that she was very worried about the health concern of her husband. She was disappointed that the disease has progressed in spite of a long prolonged treatment. Fear of worsening the disease as she failed to follow her chemotherapy regime properly, and she was obviously very stressed due to the COVID situation. So the medications we gave for controlling hypercalcemia was that she was given IV fluid, normal saline, and injection denosumab 150 milligram 4 weekly, and it was helped to attain the corrected calcium level for her. And for the progression of the disease, we treated her with palliative RT to the metastasis sites, and fifth line of chemotherapy with gemcitabine and carboplatin was started. The main concern for her was that to relieve her of pain, to maintain the calcium level, to complete fifth line chemotherapy properly, and improve the overall quality of her life. So, in a nutshell, we can say that this is a 50 years old female diagnosed as a case of metastatic breast carcinoma of left breast, triple negative with extensive skeletal metastasis, has disease progression even after 4 lines of chemotherapy, and she was found to have signs and symptoms of hypercalcemia. Thorough clinical and lab investigations confirm the diagnosis of hypercalcemia. She was treated with denosumab and adequate hydration for hypercalcemia, along with fifth line of therapy and palliative radiation to the skeletal metastasis sites for disease progression. She has responded well with this treatment and is maintaining a normal calcium level during her routine follow-ups. Now, discussion point for this cases is that how can we do proper counseling of the patient, uh, how to educate her family about such palliative emergencies, how to improve the overall quality of her life, and when to consider the palliative care for her. So thank you everyone. I'll like to end my presentation here, but I'll looking forward
Thank you.
for the valuable inputs from my seniors and colleagues regarding this discussion points. Thank you.
Thank you, Dr. Sri, for that detailed presentation on your patient. So we can take up some responses or interactions through the chat, or someone can unmute if they want to comment on this particular scenario.
Yes.
Anyone from the group about how to prepare the family in case of such emergencies and how to do counseling of the patient? And Dr. Atri, just for clarity, what counseling what is that you want to convey to the patient?
After this full chemotherapy, still the disease is progressing.
Sorry, your
And
voice is breaking. We couldn't hear anything.
hello.
Yeah, please.
Yes, ma'am. So, yeah, so I'm concerned about the counseling of the
No,
patient
we
that
can't hear you, Dr. Atri. Can you just
any.
switch off the video for a minute and just try talking?
Yes, sure, ma'am. Hello. Am
Yes,
I
yes,
audible, ma'am?
yes, it is clear now.
Yes, ma'am. So the counseling of the patient I needed to know is that how to motivate her to continue with the treatment, because already she has been getting treatment for a long time. She's demotivated. She don't want to continue it, And with the denosumab, it's causing a financial burden for families. So she's not willing to, continue further treatment, but it might be very detrimental for her. So this kind of counseling I'm looking forward for this patient. How to do counseling for her, how to motivate her to so that she could come for the regular follow-ups.
Thank you, Dr. Tree. And what do others think about when to consider palliative care for this patient? Any responses for that? A lot of silence. Someone has to break the silence. Yeah. Yeah, Dr. Haifa is telling palliative care should have started long back. Anyone else about this particular patient and when to start palliative care? Uh, yes, Dr. Shivkumar responded that palliative care should be continued along with the curative care. Thank you, Dr. Haifa and Dr. Shivkumar. I think maybe due to the lack of time, I can directly go to Dr. Vineetha and ask her inputs for managing this patient and these questions. When to prepare or when to start talking about palliative care in such scenarios, and how to prepare. I mean, you have covered that, how to prepare the family members to face such emergencies. So over to you, Dr. Vineetha.
Yeah, thank you, Dr. Sridevi. So I definitely agree with the responses in the chat box on that we have to start palliative care right from the diagnosis of this patient. Especially she had presented with CA breast and developed METs also in between, and she did have symptoms with pain due to skeletal metastasis, and she also had developed hypercalcemia, for which she was put on bisphosphonates and then later on denosumab. And now the reason that she has stopped treatment is to be actually found out. Why exactly did she start treatment? Especially like now Atreya was saying that denosumab is such a costly drug. It costs almost, what is the cost like, Atreya? It's like about 15,000, isn't it? It's like somewhere in between 12,000 and 50,000. So for the first shot, I think it is given weekly. And then after that, it is repeated once in every 4 weeks. So is it because that, the patient is having recurring expenses, and then because of the COVID also, she didn't want to go to the hospital. The fear was there. And then because if she falls sick, her husband is also sick. So whether she will give the infection to the husband, nobody's there to take care of her. All these issues are coming in. So we need to exactly find out, talk to the patient, understand what exactly is most concerning for her. If it is the finances, we should ask the patient and the family to probably talk to the physician. Does she have another alternative? Can she go back to zoledronic acid, bisphosphonates, and not for rather than continuing on these monoclonal antibody like denosumab? Can she go back to zoledronic acid for maintenance? So that can be asked, because zoledronic acid is not that expensive. Now, again, if it is the factor of that she doesn't have anybody to go along with her, so then maybe if there is some support management that the family can arrange, that can also be counseled to her. And whether she's getting enough support from the rest of the family, that can be found out in the process of talking to her. Whether is it that she's not getting relief of a symptom, she's like, what is the point of me taking treatment if I'm not having relief of symptom? No need for treatment. Is it that? So then we have to think about managing her symptom properly. right? To get her gain confidence over the treatment. And we need to set her goals also properly, because now she's already got into a fifth cycle. We need to know, understand what is her goals, on how far would she like to go ahead in terms of treatment. Prepare her and her family. It's basically advanced care planning. And how to educate her family about palliative care emergencies, like we have to tell the family that, yeah, listen, hypercalcemia is an emergency. It can even cause cardiac abnormalities, so which can become fatal. So once the patient develops hypercalcemia, there is always a tendency for the patient to develop a recurrence of hypercalcemia, and that is why it is very important to treat hypercalcemia in the best way possible. And again, she's taking denosumab. So again, we need to educate about also, mouth oral hygiene, because there is a chance for osteonecrosis of the jaw, which is again a very painful situation. So, we have to also tell the patient that, listen, you can't go for dental procedures. You have to inform your physician before you do something like that. Okay. And how to improve the overall quality of her life. Now, her symptoms, we need to understand again all the different dimensions of physical symptoms, her psychological issues that she's facing, social and functional issues, whether she's not able to go for work, or she's not able to perform her duties at home, or she's not able to interact with her other family members. What is it? She's not able to get along with her spouse, her children. What is it that is bothering her? Spiritual. Why me? Why is it that I am having to go through it? So identify which is the dimension which is most concerning her, and arrange the necessary support system which is needed. And again, the last one, considering palliative care right from the beginning, all through. So I myself answered all the questions. Because of shortage of time, I would have always put it down to the participants. How to get the answers from the chat box, but
But we had, I think, a good interaction during the session, and most of
yeah.
these points were actually brought up by everyone. So I think that should be fine. But if there are any more questions, please, we can spend 2 more minutes. Either you can unmute and ask, or you can type it in the chat before we wind up today's session. Any questions regarding palliative management of palliative care emergencies? I hope there are no questions coming up. Yeah, thank you. Thank you, everyone. And thank you, Dr. Vineetha, for such a wonderful, wonderful session that was so interactive, and everyone was giving their inputs and their comments very actively in the chat box from the beginning. Thank you so much for your time, and a wonderful session for us once again. And as always, thank you so much. And thank you so much, everyone, for being with us for the last 1.5 hours. Sri Priya?
Thank you, Pallium, and thank you to all the participants. It was really nice, and I really enjoyed this class. Thank you for your wonderful participation.
Thank you so much, Vineet.